Hi everyone, thanks for listening to all my presentations. Today I'll be talking about postpartum depression or PPD, postpartum depression. When a woman is pregnant, the expectation is that she will carry the pregnancy to term and there will be delivery. But sometimes that's not the case. There could be spontaneous abortion sometimes or therapeutic when the woman is in danger. But whether normal delivery, surgical, or assisted, once there's delivery, then there's a new lifestyle. So after delivery, some mothers will have what is known as postpartum blue, and that will be a very minor problem, right? Others will have unipolar depression, and the unipolar depression could be mild, moderate, or severe. If not well treated, like we found in some cases of some untreated women with postpartum depression, or treated but not properly treated, some women have ended up killing themselves or killing their children, and sometimes, sad enough, both. By definition, postpartum depression is the type of depression in a pregnant woman just before, during, or after delivery for up to 12 months after delivery. There are certain red flags that should give the physician, a big concern that this woman might likely end up with postpartum depression. If the woman is too anxious about the health of the infant, then we need to keep an eye. If she's doubting if she could take care of the child properly, that is a red flag. If this woman is complaining that this child has a temperament that has stressed the woman out, then we should know she's crossing the line to depression. Despondency is an English word meaning low spirit, and if that is occurring for at least 2 weeks, the border has been crossed already. If there's a lack of interest in infants' activities, when a woman has a new baby, we'll expect her to be happy, to want to carry the baby, to want to know what the baby is doing. But if she's already exhibiting a kind of lack of interest in all those activities, then there's a problem. Another red flag is lack of response to support and reassurance. Still on red flags, if this woman is pregnant, but she's on drugs, or she's a non-alcoholic, then we have a big problem. If this woman is not adhering to postnatal care, so for example, not coming for postnatal appointments, then that's a red flag. Another red flag is frequent telephone calls to the physician or even physician shopping. So they can go from one physician to another. That's a red flag. And frequent non-routine visits, just visiting the clinic, not based on the routine schedule, that is a red flag. Now, epidemiologically, postpartum depression in the Western world is about 8 to 10% in postpartum women. The onset is always before or during pregnancy in about 50% of cases. In postpartum onset, that is, those who would develop this problem after delivery, that will likely start at the first few months of delivery. Most women that would develop that after delivery will start in the first month post-delivery. And by the time you count the first 4 months, about 90% of them would have developed postpartum depression. Only a small fraction will start this problem after the 5th month to the 12th month after delivery. So, we have to keep an eye on all postpartum women till the 6th month post-delivery. But postpartum depression is possible between the 1st month of birth, post-delivery, till the 12th month. DSM diagnostic criteria for a major depressive episode. We'll go through Criterion A, Criterion B, C, D, and E. So, as per Diagnostic Statistic Manual 5, Criterion A, we'll be dealing with the following characteristics, but all we need is 5 or greater for 2 weeks. So, all these items, we just need 5 of these to occur for more than 2 weeks, then we'll make the diagnosis. Number 1, depressed mood for most part of the day. Decreased interest or pleasure. Weight changes, which might be weight gain or weight loss. Insomnia or hypersomnia. Psychomotor agitation or psychomotor retardation. Fatigue or loss of energy. Feeling of guilt or unworthiness. Lack of concentration or can't think straight. And of course, suicidal ideation. You can use MS-IgE curves to summarize this, but I will not go into details of that again because it's just going to be repetition. When we'll start posting presentations on physical examination and history taking, I'll still go over that. DSM-5 Criterion B is functional impairment. DSM-5 Criterion C. We need to establish the fact that this problem is not due to substance abuse and it is not due to medical problems. Criterion D. We must establish that this problem is not associated with schizoaffective disorder. We must rule schizophrenia out. Criterion A. We must establish that there's no manic or hypomanic episode or episodes here. So when we have gone through all those, then we need to have the points under Criterion A scored using patient health questionnaire. And we will ascribe 0, 1, 2, or 3 in the following way. If the question is about a certain point and the response is not at all, then that is 0. But if the patient responds that, well, for several days, that's 1. If the patient says, oh, it's greater than half of the days, that is 2. And if the patient says it's occurring every day, that is 3. Respectively. Then we'll put all the scores together. If we could pick 5 to 9, that is mild depression. 10 to 14 is moderate depression. 15 to 19 is moderately severe. Anything greater than 20 means severe depression. Suicide risk. Regardless of the score obtained from the previous questionnaire already shown, The establishment of suicidal ideation or suicidal behavior or attempted suicide will determine the next line of action or actions. Let me repeat, regardless of the score, even if we were able to come down to anything below 5, but when it comes to assessment of suicide risk, we're able to pick ideation, behavior, or attempted suicide that supersedes whatever score we have gathered previously. So, suicidal risk is the major singular factor to determine the line of our treatment. Risk factors. Past history of depression could be a major risk factor here, and self-report of depression is another. We can have 10-item Edinburgh Postnatal Depression Scale score, and the maximum expected there is 30. Anything greater than 10 is diagnostic of postpartum depression, but some experts will wait till they get 12 or 13 on Edinburgh Postnatal Depression Scale before making the diagnosis of postpartum depression. Still on risk factors. Marital disharmony could teach these women to depression after delivery. Relocation with associated stress. Poverty. Young motherhood, because they are easily frustrated, don't have the clue on how to handle the newborn. Single mother, because there's lack of support. Multiparity, that is, been giving birth to so many kids before, now she's exhausted, she's tired. Still on risk factors, family history of depression is a very strong singular factor, even in non-postpartum depression. And abuse at home. Oh, okay, let's talk about this. Two people in law now have pregnancy and the baby is here. The effort should be jointly delivered as per the care of the newborn. But on top of the fact that the woman is stressed out looking after the newborn, the spouse is abusing her again, then she will look at herself. What am I doing here again? Let me hand it off. Okay, that's pretty horrible. Okay, unwanted pregnancy. Of course, unwanted pregnancy will lead to unwanted child. An unwanted child will not be cared for, and the woman will look at the child with sadness. Obesity, because they are not so agile to walk around the way they ought to. Part of the risk factors could be gestational diabetes mellitus, pregnancy-induced hypertension, postpartum infection, body image dissatisfaction, personality trait like neuroticism, premenstrual dysphoric disorder. All these situations will lead to sadness, depression, low self-esteem in the mother. Still on risk factors, sleep disturbances in pregnancy, wintertime delivery. We all know that winter is associated with more depression, preterm birth, and deformed baby. The woman is sad and is not proud to present the baby to the whole world, right? Breastfeeding difficulty, she's trying her best to feed the baby, but she's not getting enough breast milk. Difficult infant. Wow, this is a serious one, right? Crying without consolation, or infant sleep disturbance, particularly in the mother that are having the baby for the first time. They have that problem because they have their own circadian rhythm already, or internal clock already built, over years. Now somebody new has just come in, crying at any time at night, morning, noon, anytime. They just, and then the woman is, what's going on? I can't just have a nap anymore. So you can check my channel for a full presentation on crying baby. I think I made a publication already that span almost 20 or 30 minutes. Check my channel for crying baby. Pathogenesis. We don't really know the exact cause of this problem, but some hypotheses are out there that both genetic and environmental factors are huge contributors to postpartum depression. Hormonal changes, psychological problems, social problems, and stressful life events are all negative influences that could lead to postpartum depression. Now, how about hormones? Low estrogen and low progesterone, and alteration in cortisol, melatonin, oxytocin, and thyroid hormone level. How about the placenta? Increased placenta corticotrophin releasing hormone at the 25th week gestational age could be a strong predictor of postpartum depression at 9 weeks after delivery. Neurotransmitters. A drop in dopamine and serotonin level, including low level of norepinephrine due to a high level of monoamine oxidase A in the anterior cingulate cortex, is also a strong contributory factor. Clinical features. You can make use of MSIG caps, but don't worry, I'll soon start presentations on physical examination and history, so I'll delve into that, more later on. Okay, when it comes to severe postpartum depression, it will be characterized by the onset will be in pregnancy, and there will be a high score on Edinburgh postnatal depression scale, as high as 20 or greater. There's likelihood of anxiety being present, and of course, suicidal ideation or suicidal behaviors. It's likely going to be associated with postpartum hemorrhage, low bed weight, or sometimes, sad enough, fetal death. Still on clinical features, there's likelihood of comorbidity, for example, postpartum depression with generalized anxiety disorder. What is the cause of this disease? It could resolve spontaneously on its own, could resolve with treatment, and could become a chronic depressive disorder or a persistent depressive disorder. Well, I would choose the first one if I have the opportunity to. What are the effects of postpartum depression on the child and the mother? The first thing is low breastfeeding. We've been talking about the fact that this woman is down in the spirit. She's not happy. So, she's low. Psychomotor retardation, right? So she's not doing what she's expected to be doing. Low bonding with the infant. Of course, that's not surprising, right? Because she won't even like to handle the child. Okay? Low immunization. Someone that is not excited about herself, not excited about the child, will not present the child for routine immunization. And of course, when there is low feeding, low bonding, no immunization, anything could happen to that child, right? Including decreased infant development. Then, high marital disharmony. Of course, either high marital disharmony is leading to this, or this will lead to marital disharmony, depending on the spouse. High cognitive impairment and child psychopathology is going to have adverse effects on the child. Let me reiterate here. I have a separate presentation on breastfeeding. Within the first 2 years of life, the central nervous system is still developing. By the time the child is delivered to the world, the central nervous system is not yet fully developed. So the first 2 years of life is critical for full development of the central nervous system in any child. So this child is here, the first few months of life, no bonding, no good breastfeeding, no immunization, no affection. And what do you expect to happen to that child cognitively? Of course, there'll be impairment, right? High suicidal ideations and frank suicide. Yes, somebody that is depressed and not being attended to will likely end up committing suicide. Okay, can even lead to infanticide. They can kill the infant. Yes, and that is why I said earlier that out of all the risk factors, all the scoring and no scoring of questionnaire remarks, either Edinburgh or DSM or whatever, once you could pick suicidal ideation, suicidal behavior, or attempted suicide, then the treatment should be directed at checking that first. Then you come and address the rest issues. ISIDA, that is sudden infant death syndrome. The child has not been well catered for, could lie, prone, and then die from there. Screening. Start screening from the red flags that I've listed earlier, but the best way to help all pregnant women is start screening for postpartum depression during antenatal clinics. And intrapartum focus on dysphoria and hedonia, worthlessness or guilt, lack of concentration, and of course, suicidal ideation or suicidal behaviors. Differential diagnosis. Postpartum blues. Postpartum blues is a mild situation and is self-limited. It's going to occur in the first 2 to 3 days post-delivery, and it will resolve within 2 weeks. There's likelihood that what we're dealing with is normal postpartum changes. And it could be a bipolar depression, but that will be associated with mania and depression. And we might be faced, or we are dealing with psychotic disorders. It could be postpartum psychosis. That's a different diagnosis, right? And I will publish a presentation on that in the next few days. Still on differential diagnosis, it might be minor depression, which means it is unipolar, with 2 to 4 depressive symptoms lasting for 2 weeks, no mania, no hypomania. When it comes to the treatment of postpartum depressed women, we must never joke with anything around suicide. Never. There was a sad case on the news of a woman with postpartum depression taking off her antidepressant, and a week later, she killed the child and killed herself. That was sad. Okay, in any woman with postpartum depression, we should have one fact be at the back of her mind. She will be willing, she would love to, given all factors right with her, she'll be willing to breastfeed that child. So we should help her, even if I've not stated it here, we should help her to express breast milk and hire someone to help her breastfeed the child. Okay, then we'll follow certain steps. Number one, we have to decide quickly whether we are going to admit this woman or not. And one major factor to lead to admission is suicidal ideation, suicidal behaviors, or attempted suicide. Then, is there marital disharmony, or this is a single mother who has attempted to hurt this infant already? We have to admit. History of past postpartum depression and treatment should be established. We have to educate the patient and family members on the diagnosis and the best way or ways to support her. We have to advise that this woman must keep to the treatment, and we must be monitoring the symptoms. We can give antidepressants, and we have to follow up very closely, keeping an eye on suicide, because why would I do that? Some of these antidepressants on their own could lead to suicidal ideations, suicidal behaviors, attempted suicide or frank suicide when the depressed woman gains energy. Okay? And that is why when they are on antidepressant, we'll still monitor them for suicide, particularly in younger women. But that is not to say the older women should not be looked after when it comes to this. So give antidepressant, keep an eye on probability of suicidal ideation, suicidal behaviors, attempted suicide, or sometimes when we are careless, the woman would have committed frank suicide. If you can't handle this, there's no crimes, it's not a crime, refer. Okay? And of course, psychotherapy could be administered also. You have a lot of antidepressants to select from. If you check my channel, you'll see a self-representation on the list of antidepressants. And then, if you go into my channel later, you'll see that I've published a self-representation on Zoloft, that is sertraline, another one on venlafaxine, another one on Cymbalta, another one on mirtazapine, even nortriptyline. So you have a lot to choose from. That woman should not die. We can add psychotherapy with lorazepam to a depressed woman postpartum with anxiety. Let me explain. You can embark on psychotherapy and lorazepam if this is postpartum depression and she's anxious at the same time. If this woman is agitated, that is postpartum psychosis, right? Give antipsychotics. Note this. If this woman is on an antidepressant before delivery and the antidepressant is working well, why changing the winning team? You just continue with the same antidepressant. That makes your work easier, right? And the woman will also like it, right? She's not changing anything new. Okay, we can add second generation antipsychotics like risperidone, or we go for lithium. And somebody is asking me, what's the business? You are talking about postpartum depression, and then you are adding lithium. Yes, I have a business. The business here is that this is a woman with depression. when the antidepressants will start working well after 2 weeks, we may tilt this woman to mania, and we need something to stabilize the mood. That's why risperidone or lithium will be helpful here. We can also give aripiprazole or olanzapine. You may use tricyclic antidepressant, particularly I'll be comfortable with nortriptyline, but because of the anticholinergic side effects and the horrible side effects on cardiovascular system, this will be the last medication that I will touch. Okay, avoid bupropion and ozepine and use less of fluvoxamine. If you've done all these and still you are not winning, which means the depression is refractory to the medications you have prescribed, we have one way to go again. That is ECT, electroconvulsive therapy. But if this woman will not be ready for electroconvulsive therapy, you can use bresanolone. Bresanolone is meant for patients who would decline ECT, or you have applied, you've tried the ECT, she's not responding well. You can use bresanolone. I have little information on bresanolone. I will make my own research on it more and then have a separate presentation on that later on. So more on bresanolone later on. You can check my channel for that. So with that, I've come to the end of postpartum depression, from postpartum blue to postpartum depression. We want both the mother and the newborn to be alive. We don't want the mother to kill the baby and kill herself, or kill the baby and continue with suicidal ideation and suicidal behaviors. No. We want both of them to be happy and the entire family to be happy. So we will start doing our job from the first day at the antenatal clinic. Thanks for listening to my presentation. Remember to subscribe. Remember to leave comment. You can give thumbs up. You can send this to your friends. Share it with all women you know that are pregnant or those that you know that are suffering. And remember to subscribe to my channel. I appreciate it.